The meeting is now formally open. You have before you, or you have had the minutes of the meeting of the 7th of February 23. Have you had the minutes?
Yeah.
Okay. Okay to pass those. Okay. So let's move on to apologies. Any apologies, Mark? Okay.
Apologies from Councillor Holmes.
Okay. Okay. Any declarations of interest looking at the agenda, please? No, none at all. Okay. So we now move on to the Code of Joint Working Arrangements for Health Scrutiny, and the presentation is from Mark Jenkinson. Over to you, Mark.
Thank you, Madam Chairman. Good evening, members. For those who don't know me, I'm Mark Jenkinson. I'm Assistant Director for Community Services, South Staffordshire Council. Quite timely, as this is the first committee meeting of the Wellbeing Select Committee, so appreciate some members have been involved in health scrutiny and part of the District Council for a number of years. For those who aren't, hopefully we'll set the scene in terms of our role in terms of health scrutiny and how that works in conjunction with the County Council. The Code of Joint Working has also been to Cabinet today to be signed off, so shortly a decision will be going out for all members, which recommends we sign up to the Code of Joint Working along with the other 8 districts and boroughs within Staffordshire. So hopefully it will give you a little bit more insight into the role we perform in health scrutiny. But again, that will be going out shortly this week, so members will have an opportunity to look at the information before that decision is made on behalf of Councillor Lees as the leader of the council. So the Code of Joint Working for Health Scrutiny in Staffordshire, initially following the Social Care Act in 2011, the Act was amended to give local authorities the powers to scrutinise social care, public health and health functions. As members will be aware, ourselves, Staffordshire is a 3-tier authority. There's various levels of where that scrutiny function takes place. In 2003, initially, the districts and boroughs and the County Council agreed a set of principles in terms of health scrutiny and how that would be carried out within Staffordshire. That was reviewed again in 2015, and currently we're back at a point in time in 2023 where we're reviewing that process. So the terms of how that function operates have been slightly reviewed and amended, but the general principles of that are any wider health functions, so predominantly NHS functions, adult social care and public health, those functions are scrutinised on the county level by the Health and Care Scrutiny Overview Committee at the County Council. Any local issues can be scrutinised at a district level, but we need authority and commitment from the County Council to do that. Key elements of that are, as members will be aware, big county across Staffordshire. If those health providers are being called to the County Overview and Scrutiny Committee and 8 districts and borough committees, a lot of their time then is spent within those committees. So functions which impact on the whole of Staffordshire are looked at and scrutinised at that level on a county footprint, but with agreement of the chair via Councillor Chapman, we can look at localised issues. So the predominant role of this committee is to oversee and overview any functions that impact on residents' health and well-being. And as a district council, that's a lot of our functions ultimately have an impact on our residents. So that's what we call the wider determinants of health. So not NHS provided services, but those functions that we deliver that impact on our residents. So later on today's agenda, Maggie Quinn and Mark Moore will be giving a presentation on community safety. Again, that's one of the functions that falls within the remit of this committee. Likewise, leisure services, street scene, planning functions, or the localities agenda all have impacts on health and wellbeing, and they're all functions which this committee can look at and scrutinise from a district council perspective. Some of the general principles in terms of our arrangements regarding health scrutiny, again, it's intended that the outcomes of these committees is to improve the benefits in terms of health and wellbeing outcomes for our residents across South Staffordshire. Operating within a 2-tier or 3-tier authority, it's key that there's cooperation between ourselves and the County Council on these agendas. A lot of the work stemmed from the Francis report and some of the issues that were found that came out of that investigation in relation to Stafford Hospital. There was elements that fell between the gaps, elements of duplication, but also where things got missed. So the process has been put in place to hopefully avoid some of those challenges that previously were found within South Staffordshire. Again, although we can scrutinise some of those health functions at a local level, the accountability ultimately sits with the statutory powers which are owned by the county council. But signing up to the joint code of conduct, we are in essence agreeing that we will work with the county council on those principles and the terms and conditions of what we can ideally scrutinise at a local level. In terms of the governance, we obviously operate this committee, the Wellbeing Select Committee, which is our health scrutiny function at a district level. As I've stated previously, the County Council operate the Overview Health and Care Scrutiny Committee, which is made up of 13 county councillors, and each district and borough chair has a seat around that table and is a constituted voting member and has full voting rights. So Councillor Chapman, as chair of this committee, will be the district's representative on that committee. If for any reason Councillor Chapman can't attend, Councillor Williams will attend as deputy. But again, we do have delegated powers that we can authorise another member of the council to attend that meeting if, due to unforeseen circumstances, the chair or vice chair cannot attend that meeting. So again, just to summarise, County Council will overview and see any public health functions, any adult social care functions, and our NHS functions. So that's any hospital provisions or any services which are operated by NHS. We can carry out scrutiny of those functions as we have done as a committee previously, but we need to ensure via the chair that those discussions have been agreed in advance with County Health and Scrutiny Committee. Again, each district and borough will operate in line with their own. Sorry, Mark, next slide. I'm going off my slides, not yours. Sorry. Next one, Mark. Sorry. Apologies, members. So, sorry, Councillor Sun.
Madam Chair, will ask a question at the end, right, as we go through each slide, just saying as we go through each slide.
Yeah.
It goes through. Yes, yes.
I know that County Councillor Abrahams is listed as an attendee at this meeting. I've been on this Health and Select Committee now since 2015.
Yeah.
I get to see a County Council representative. We go through this conversation every 4 years when we start, and we review it on a not too frequent basis. I get to see a County Council representative, and I'm sure that our chair, or in her absence, the vice chair, will attend all the County Council meetings.
Indeed.
But I ask, though, by the chair, and perhaps we would point out to County Council, we do have a County Council listed, you should be a County Council representative here. Surely they're giving us the courtesy to attend one of our meetings.
Yes, that's a fair comment. Yeah. Okay.
So yes, apologies. I was going off my slides and Mark's driving at that end of the table, and I've not given him the nod. So apologies for that, members. But yes, as Councillor Sutton has alluded to, as we have the right to have one representative on the county-wide committee, likewise we do get allocated a district member, and for ourselves it's Councillor Jack Abrams, who's I think the Purton County Councillor. But again, via Councillor Chapman, we can make those points known. So again, hopefully, members, that gives you an overview of the level of health scrutiny and what we can pick up as part of this committee and what falls under the county wide functions. Again, next slide, please, Mark. Again, we've covered representatives on those committee, and likewise, we've got rights to sit on the county committee, but again, county councillor is allocated to this committee. Any questions on that, members? Happy to take them now. Again, we will pick up at the end of the meeting in terms of the work programme. We have got one agenda item which will follow through to our next meeting. However, members, if you have got local issues or any challenges in relation to health in your patch, please, via myself or directly to the chair, let us know. The committee works much better when we get local issues coming through from yourselves on the ground, and then it gives us some meaningful health scrutiny. Again, there may be issues which are discussed at a county-wide level, and via Councillor Chapman, we can bring those back and potentially get the relevant partners to come and talk to us.
Okay.
At some stage, we had the GPs.
Yeah.
This is one of these meetings. And certainly in the last 4 years, we've never had GPs attend. I just think if we're talking about local issues, and quite often it is the GP surgeries. I'm sure out of the practices, one of them could spare an hour now and again to come and see us.
Yeah, I have to say, Councillor Barrow, some years ago when I was chairing Wellbeing, quite a few years ago, we did have representation from the GPs. Okay.
Just to come back on that point, Councillor Barrow, as part of the new joint code of conduct, what has been put to us as councillors, we can't scrutinise GP practices directly, as they don't form part of the health scrutiny function. Ultimately, they're commissioned by the Integrated Care Board and they're an independent body. So the line we've got is, if we've got any issues with local GP practices, that representation needs to be made directly via the ICS. We can't bring them to health scrutiny. So that's a subtle change that has been put forward. But again, that's not just us, that's the county council as well. That's been put in place, that the ICS have to take that action. Ultimately, we can't scrutinise them.
Councillor Barrow.
I'll give you some idea of what we can scrutinise.
Yeah.
Most of the problems revolve around the GP practices, one way and another. So, you know, it gives us a very limited area if we take all of those issues out.
Yes, Councillor Barrow, that's a valid point that's been put forward. Again, where we've looked at that previously, I think that's always been the case, and technically the GPs don't have to come and be accountable at a scrutiny meeting. But if there is local issues, it's important that, again, that it's fed via to us, and it might not be in this forum, but it's potentially the ICS will do that on our behalf if we've got any issues within our local GP surgeries within patch.
Councillor Sutton.
The majority of our residents, those individuals that we have sitting around and coming to talk to us, their number one issue, we carried out a survey in the last 6 to 9 months. The biggest issue for every single person on that survey was access to GP services. Now you're telling us that we don't even have a gateway to pass that feedback on to GP services. How on earth are we, as supposedly an overview or a part of the overview scrutiny system within the district council, going to get the feedback to the right people to make a change? I'm sorry, but this gateway is not open, you're saying. What other alternative have we got as a select committee, part of the overview scrutiny, giving the feedback back to somebody of 43,000 residents who live in South Staffordshire? What's our access? How are we going to do this? We've been elected to represent those people. Give us the tools to do it, or find us the tools. Madam Chair, I'm less than gripped. I may not be as articulate as Councillor Barrett, but I think I'm reflecting exactly what she's saying.
I think you are, Councillor
So there's two factors to that. In terms of the individual performance of the practices, we can't carry out that scrutiny function. But in terms of GP access, that is a primary care function. So if there is GP access issues, that can be picked up in terms of the county-wide overview and health and care and scrutiny committee. That can be looked at, because GP access is a commissioned service across all those practices, so it can be looked at in that forum.
Councillor Sutton.
Chair, thank you for that, Mark. Can we also include within that other services such as dentistry? I know we've seen recently in the last few weeks some real strange horror stories from dentistry. But I was talking to 2 residents last week who are desperately trying to find NHS dentistry services locally and cannot. Is that something that this committee can feedback as well?
Again, on a similar vein to the GPs, Councillor Sutton, dentistry will be looked at as part of the county-wide contract. But again, if we've got any specific issues via the chairman regarding any of our local dentistry practices, it's potentially something that we could look at, but we'd need approval from the chair of county health scrutiny to look at it locally.
Totally agree, Mark. I think it's a generalisation from a point of view of having access to NHS dentistry services, which is the issue. It's not specific practice. It's who out there is actually providing NHS services.
Yeah, it's a slightly difficult one because it's commissioned by NHS England, so it's NHS England led, not the local NHS provider. But there is an option to look at scrutinising dentistry via the Health Fee Select Committee at county level. So hopefully, if it's not picked up at that level and there's agreement, we potentially could look at it if there's any local issues.
Okay.
That's not a good way to behave. Where we as district councillors, as Councillor Sutton said, we need to represent the people. If they're not there to listen to us, you know, they're not gods. And unfortunately, they should, like the rest of us, we should all be accountable. We all should all be open and transparent to listening. And I don't think that level of GPs and dentists, etc., are prepared to do that. And I think that's where we fall down with the community, because they do feel they're not listened to. And certainly the GPs, they may pay lip service, but they're not listening as a body.
Yes, thank you, Councillor Barrow. I would just say that Councillor Sutton did mention the survey we did over a long period of time. I have to say that the GP practices were one of the major concerns of the residents. I'll now call upon Councillor Williams.
Mark, couldn't we get in touch with the County Council health group names, ask about GPs, where they are and what's happening? Because obviously we've got to go through them. Well, we've got problems and we need some answers. Would you be able to do that?
Excellent. Thank you, Councillor. Yes, by the chair, we can make that representation. I don't think it would come as a surprise to members that this is an issue for all districts and boroughs across Staffordshire, and rightly or wrongly following COVID, things have changed, and obviously GPs are operating different models in each of the patches. But again, it's a common theme that's come through in terms of GP access, and I fully agree with the comments and support. Ultimately, we're all here to represent and support our local residents, and it's important that that's picked up. But I think it's a common theme and something that will be looked at a county level. But if we can influence and make those views known, what I didn't pick up as part of the presentation is as part of the ICS's health scrutiny as a whole will be reviewed this year, and the Secretary of State will have different powers, so there may be some slight tweaks and changes to what we can and what we can't do in conjunction with the county. But I think the view was at this point in time it was to re-sign up to the joint code of conduct and try and have that positive relationship with the county on those matters. But again, it's not forgetting the local angle and what people are telling yourselves as local members, and it's how we then feed that up via Councillor Chapman.
To next subject.
There's no other questions, Chairman. Yes.
No more questions. Okay, that's great. Thank you. So we're now moving on to South Staffordshire Community Safety Partnership Action Plan 2023-26, which is a presentation by the Community Services Manager and Community Wellbeing and Partnership Officer of South Staffordshire Council. Mark, I'm ready to go.
Oh, thank you. Can everybody hear me okay?
Yes.
Fantastic. Yes, I'm Mark Moore. I'm the Community Services Manager for the council. That includes community safety, street scene, and leisure services. So as Mark said, those services that are very much are available to scrutiny from this committee.
Can you put your mic on, please?
It's not working, unfortunately. Sure. Sorry about that, that was better. My colleague Maggie Quinn, who is the Community Wellbeing and Partnership Officer, and very much the lead in the community safety space for the District Council. So just by way of introduction, really, and a bit of plotted history or recent history for community safety as a service. So community safety has recently moved from where it previously sat within the revenue and benefits function within the council to community services. That's a recent change, recent as last month. The main reasons for that change and to look at exploiting some of the synergies that exist with some of the other services that are within community services, so particularly in links with environment crime, with street scene, within leisure services, and the role that all those can play with impacting on the community safety agenda and action plan that we'll come on to in more detail. By coming into community services, it also helps us to provide additional support around community safety and to improve the resiliency with that service and bringing about those efficiencies from that perspective as well.
Okay then, so looking at the governance arrangements for the Community Safety Partnership in South Staffordshire, you can see right from grassroots level, we talk to parish councils, councillors, both district and the county, and the public about any concerns they have, but also any opportunities there might be in the community safety world. And those are fed up through locality community safety forums. And some in community engagement events. That's what we're focusing on right at the moment, to develop that side of talking to the public too. Then that feeds up into an operational conversation, which are two hubs. One is the vulnerability hub, which is led by South Staffordshire Council, and the other one is the harm reduction hub, which is led by Staffordshire Police. But they both look at the most vulnerable people in our district who are affected in any way by crime, disorder, or antisocial behaviour. And then that leads up into the next level of conversation, which is both operational and strategic, which is a local South Staffordshire Community Safety meeting, the Tactical Priorities Group, and Domestic Abuse MARAC, Multi-Agency Risk Assessment Conference. So there we look at high-risk cases, we look at what's happening in the here and now and putting strategies in place to tackle, put resources in place to target. And then that then feeds up into the wider partnership conversation, strategic responsible authorities group. So the Community Safety Plan has just been refreshed, began on the 1st of April 2023 and runs for 3 years. What we've done is we've highlighted priorities within the plan, which will be 3 years, but they will be tweaked as we go through the 3-year period, because obviously there may be some emerging priorities that then come to the fore that need a little bit more focus than some that we've already identified. So the partnership brings together all the agencies in the district that have an impact on crime, antisocial behaviour and the fear of crime. And that's all types of agencies, up to about 30, that come together to join the conversation as and when required. Keeping our community safe is everybody's responsibility, and the logo that you can see on the right is something we're developing, and that's going to be our main focus for social media and for communicating through newsletters with the public, because what we want to try and get the message across is it's not just about agencies working together, it's actually about the whole of the community working together. And obviously out in the communities, everybody are eyes and ears that can help to keep everybody else safe. So it's very much bringing the whole of the district together to talk about community safety. And then the plans and priorities are based on evidence, they're based on intelligence. So it's not just picking out of the air, it literally is looking at what has affected our residents over the last 12-month period and then putting actions into place to address those issues. So the priorities identified through strategic assessments, through our locality plan, through the police information that we have, through public consultations as we've presented that information to the public and councillors, here are cross-border crime. We live in a district that is surrounded by other conurbations, and definitely cross-border crime has an impact on our crime levels. Vehicle crime, unfortunately, has been hit over the last 12 months. There has been quite an increase in vehicle crime, specifically keyless entry cars. A lot of social media, a lot of publicity has been done about it, but it's not that easy to fix. But we have been putting in place some measures to try and focus specifically on vehicle crime, but obviously all crime is included in that too. Serious violence. Local authorities have recently had a new duty placed upon them, which is the serious violence duty. So we actually have a duty to reduce serious violence, which includes domestic abuse and violence against women and girls. Both of those are strategies from the government. Antisocial behaviour, that always is prevalent in all of our communication to people, what antisocial behaviour is and how it can be addressed. So it's something that we want to continue because it has many guises. Community cohesion, we definitely want to bring this to the fore as well, especially seeing as we've just had the Ukrainian guest being placed within our district. We've got 2 hotels which are full with asylum seekers currently at the moment. So we very much want to bring those into the conversation as well, because they are being integrated into our community and are here to stay. And then perception versus reality, which is very much people feeling reassured in their local area, in their homes, when they're out and about. And it's making sure that the perception of high crime is given the relevant information and intelligence so that people can see that actually we haven't got the high crime that our neighbouring authorities have. We've got some secondary priorities as well, and the reason we've put these in is because these two have a high impact on our local communities. So although we will be focusing on those priorities I've just talked about, these also will be something that we'll be keeping a watchful eye on. Fraud especially, this is high throughout the whole of the country. Fraud is a problem, and it happens in a lot of ways too. So what we do is we've done a social media campaign. We're always talking about fraud and what scams can look like, what to do if you have been scammed, who to contact, how to report it. Rural crime is obviously an issue. South Staffordshire, we have some very rural pockets, and it's making sure that those communities feel reassured as well, are given the advice and support that they need. Road safety, we have motorways running through us, we have arterial routes running through us, we have a lot of country lanes, and it's making sure that people listen and watch out for what is expected of them on the roads. Drug use and drug dealing, this falls very much within the category of antisocial behaviour as well. There's a higher percentage of cannabis use being detected now, being monitored by the police. So we want to make sure that we're mindful of that, and also county lines. A lot of young people, child exploitation are being brought into drug movement around the district and from and to outside and in the district as well. And then health and wellbeing. We're very conscious that health and wellbeing is affected by community safety. The vulnerability hub that I mentioned, which is run by South Staffordshire Council, we talk about people who are vulnerable for one reason or another because they have become affected by crime, antisocial behaviour, crime disorder, antisocial behaviour. 75% who are being discussed at the hub at the moment have mental health issues or health issues. So there really is a link between them. Domestic abuse has the toxic trio, of course, which is and I can't remember the toxic trio, I'm so sorry, it's totally gone out of my head, but mental health and alcohol, and obviously violence is included. That's the, thank you very much, in that mix. And also we want to look at disability and neuro disability as well. So how are we going to tackle them? Well, really, it's through that structure that I have explained. We've got the governance in place, and it's just through that governance structure that we're going to be looking at cross-border crime, and we're going to be using tools as well as the structure. We've got CCTV, we've got 12 cameras which are deployed around the district. We have ANPR, so all our arterial roads are covered by automatic number plate readers, so that links into the police database as well. We have speed indication devices, which we'll talk about later. But again, that is involved in the whole process of making people feel safe, but tackling crime around the district as well. Serious violence, we have the governance arrangements in place through the multi-agency hub, through the domestic abuse multi-agency risk assessment conference as well. The antisocial behaviour, that's coming down to community safety is everyone's responsibility. And we have a victims champion in South Staffordshire who is funded by the Police, Fire and Crime Commissioner. We have the locality-based projects where we want to bring antisocial behaviour out to you, what can be done about antisocial behaviour, how people can work together to address it, make sure that people are feeling safe and secure. And community cohesion, so we've got that governance structure, also making sure that we have regular engagement with members, parishes, residents, working together with partners. This is a new area in a sense for South Staffordshire. Obviously other local authorities have been dealing with it, talking about it, putting in place measures for several years now, but because we haven't had the placement as such previously, we are now beginning to look at it and put policies and plans together. And again, perception versus reality, this is very much getting the message out and about in the public domain, getting conversations started about community safety, about a safe place we are to live in, about how the residents and all of us can help each other. The outcomes then, what we want to achieve.
Maggie, can I stop you there?
Yes.
I'll give you a breath, Sarah.
Yeah.
Thank you, yes.
Yeah, if I could ask a question.
Please carry on.
Turn back to the slide of tackling, please. 2 slides back. Yeah. 2 slides, the marrow and the book everything very good. You know what I'm going to ask. Because obviously, the last time I checked the direct nomination list, we had people who were subject to domestic abuse, who are waiting to be housed. We've had frustration, as you know, with the housing associations. Have we made any progress forward in relation to getting some housing association representation on either of those 2 particular meetings to try and resolve the issues on the direct nomination list, or to remove that lady who's for the last 18 months been sitting in a refuge waiting to be rehoused in South Staffordshire?
They are represented on both of the
What are we moving forward with then?
it's because it's the policies within the housing associations themselves, and we have done a little bit of digging in that house that we were talking about. We alluded to, both of us. It didn't fit for people to move into, yet they've still got repairs, so there isn't anything that we can move forwards on them. I know that every housing association gives us their allocations, apart from Homes Plus, which gives us 80% of their allocations, but they manage those themselves. They manage who goes where. We don't actually have a say.
I agree though, something.
Sorry.
I appreciate what you're saying, Maggie, but the frustration is having walked the streets and seeing perfectly good houses, 3 and 4 bedroom properties, some of which are well kept, they're clearly been maintained, they're clearly ready for use, empty. I can take to 3 in my ward alone. And I look at the direct nomination list, and those families sat on that direct nomination list, and somewhere there's a disconnect. That's very, very frustrating. And again, I ask the chair, please, we are here to support. You talk about support of our families, our vulnerable families. The most important thing is to get them to somewhere into a home and not a bed and breakfast or skipping and sofa surfing. And I appreciate that the housing associations have lots of policies, but the reality from my perspective is you need to kick somebody's bottom. Again.
Sorry, Maggie.
No, it's okay. We are obviously we are obviously mindful of all the people who need to be rehoused. Very mindful of where they need to be rehoused because of the issues that have happened in their previous relationship or what have you. But yeah, it's something that we continue to talk to as an association about.
I appreciate it.
Of course.
I appreciate my chair talking, but there comes a point where talking, getting nowhere, and this is the same conversation we keep having. We're not seeming to be able to say to the housing association, come on, folks, we need to rehouse these people now, not in 2 years' time. How long are these children going to be brought up sleeping in a 1-bedroomed grandma's flat? 4 children and a newborn baby. How long are people having to sit and what have you? I'm sorry, but it's a plea. How can we change this? How can we make it important enough to get the housing association to move forward? I'm not the only one who's seen empty houses, housing association properties in their area. I'm sure everybody around this room has. How do we get it there? Sorry.
So there's just a question I'd like to put to Maggie. Do we have any idea how many vulnerable people and families on the books? Do we have any idea at all?
Our housing team will, yes. Our housing team will has done 9. Okay. But obviously, I used to think very closely to Michelle Kettles in welfare services, so I will have another conversation with Michelle to find out where we are.
Thank you, Maggie. I'll call Councillor Barrow now.
Maggie, I think it's like all services, I think we've gone from one service to another who are not working together. How many times do we sit here week after week, year after year, saying exactly the same about housing association? They're not prepared to work with us closely. And I think just to get to actually speak to someone in a housing association, you're very lucky. And until people realise that things are only going to succeed if we all work together and speak together. And until we can, I mean, they come from the housing association, they can sit here on the top table and come out with a dribble, you know, how wonderful they are and how much they want to do and blah, blah, blah. But when it comes down to the grassroots, we really have a struggle working with the housing association, and that's got to stop. There's got to be some movement whereby we can liaise with them better,
Yeah.
that we know who to speak to, and we get some outcomes. It's always tomorrow with them, or, you know, unless you actually stand up and actually scream at the top of your voice and threaten them, we don't seem to get anything done. Thanks for that. I'll take it back, have conversations, but, okay. On to the outcomes then. So for the next 12 months, the outcomes we want to achieve, we want to reduce all recorded crime by 2%. We want to reduce vehicle crime by 2%. You may not think this sounds very much, but because we've had such an increase in both crime or recorded and vehicle crime, that is an order, actually. I don't know how to. To increase the number of repeat victims of domestic abusing services by 20%. That's quite a lot, but we have seen a lot of victims of domestic abuse coming forward and actually reporting, which to us is a positive. We want to increase that. To reduce serious violence, including violence against women and girls, by 2%, to reduce antisocial behaviour by 3%, and to maintain the high level of feeling of safety during the day, which is 88% currently, and after dark, which is 67% currently, to maintain that good feeling of safety when out and about. I'm conscious of time, so very quickly, I'm just going to tell you the current figures as we speak on a 12-month rolling programme. So this time, 12 months ago, we are 17% up on all crime, unfortunately, but that is less than it has been. It is a reduction, but it's still an increase, unfortunately. Every single neighbourhood has had an increase in crime, albeit the figures aren't high, but they've all seen an increase. The domestic abuse has seen an increase of 17% as well, but do be mindful that there has been a new category of non-fatal strangulation included in violent crime. And with that being included within the violent crime figures, that has pushed up domestic abuse. So that's gone up slightly, and it's only Kimber that's seen a slight reduction there. All the other areas of the district have seen a slight increase. However, end on a positive, 32% decrease in antisocial behaviour, which is very good to hear. And let me just see, everyone apart from Kimber, every area apart from Kimber has seen reduction, but we're talking quite small numbers in Kimber of 9 difference. So we are talking small numbers there. Okay, any further questions?
Councillor Evans.
Thank you. Yes, can I just ask about the starting figures for the outcomes? Where is the starting figure? Oh yes, sorry.
Okay, the starting figures have basically come from police figures and intelligence that has created the priorities. So as I said, we've gathered all the intelligence, and it's from that baseline that we've suggested those figures.
Thank you, Maggie. Councillor Kath Williams.
Maggie, question for you. Is our crime figures still involved with prisons?
It didn't used to be. We did actually used to take the prison figures out.
Yeah.
However, I've got a feeling they might have got back in again.
Yeah.
To the purpose of that.
Yeah.
Yes.
It does have to.
Yeah.
Yes, it
It
does.
doesn't go again.
They do need taking out again. So that is a question I will ask when we get our figures assessed again.
Thank you, dear.
Okay. Any more questions, please? Right, okay. So thank you, Mark and Maggie. Okay, thank you. So we now move on to Health Watch Staffordshire update. presentation by the Health Watch Staffordshire Manager Baz Tamiz.
Can you hear me clearly on that? So my name is Baz Tamiz. I'm the Manager of Health Watch Staffordshire. Thank you for having us here today. With me today, I've got my colleagues, Dave Bassett, who covers the South East, and then Daniela Ballantyne, who covers the South West, taking over from Robert O'Leary, that some of you may have met last time. We'll be doing a short presentation. We will take questions and answers at the end. However, if you do have a burning question, we're happy to take that along the way. I thought it was quite good to bring Daniela along because I know some of you previously met Robert, and give you a chance to meet Daniela as well. And we'll start the presentation off with a little bit of background about Health Watch. Just for those of you that may not have come across this before, it's just interesting, I mean, before starting this presentation, how relevant some of the stuff you're talking about when it comes to access to primary care and lack of appointments for NHS dentistry, and we're picking that up as we go through the presentation. I'd also like to say, as a Health Watch, we are here. If you have patient experiences or resident feedback, please pass that on to us, and we'll be able to show how we can escalate that as well. And another thing I'd like to add, and just picking this up as I was listening, I do remember having a conversation with Tracy Shewan, who is the Comms Engagement Director with the ICB, who's going to be doing an update to the Healthcare Ovary Scrutiny Board with Cancer Jeremy on next Monday on the 12th. So it might be something you might want to see if you can tap into that as well, just to see what's going on from the ICB perspective of dentistry. Yeah. So again, a little bit of background about what we are, what is Health Watch, a chance to meet the team, how we came about. So effectively around the 2005, 2008, there was a lot of whistleblowing coming out from them, what is now the county hospital. Back then was known as the Midstaff scandal, where Cyril Francis led an inquiry into that. And then that kind of went forward, springboarded forward, and kind of gave rise to the idea of Health Watch through the Health and Social Care Act in 2012. We'll be covering a little bit about what we do, how we operate, enter and view, so our statutory powers to do visits to any premises paid out of the Health and Social Care purse, and about systems changing how we influence Health and Social Care service, set agendas, policies, and procedures. So Health Watch is your health and social care champion. As an independent body, which is statutorily required across England, we have the power to make sure that those making the decisions listen to your feedback and improve standards of care. It's really important that you share your experiences, whether good or bad, happy or sad. We use your feedback to better understand the challenges facing the NHS and other care providers to make sure your experiences improve health and social care services for everyone. We can also help you to get good quality information, advice, guidance, and signposting to appropriate services. Move to the next slide. Sorry, the next one again. I'm catching myself on one. So this is the current team at the moment. So as you can see, we have Dave Bassett in the South East, Danielle in the South West, and we have Emma Ford in the North covering Staffordshire Moorlands. We have also Claire Hill, who's our data analyst. Again, the reason why it's important to reiterate this again is so you can touch base with us whenever you need, catch up with us, drop us a line, an email, and we'll try to liaise with you about things that you're picking up within the health and social care. So a little bit more about Health Watch background. There is the National Health Watch England. We then also have local health watches that exist across major towns and cities, about 150. So we have our own Health Watch Intelligence Network, the wider network. So what we do is that when we collate this information, we can then escalate this up to Health Watch England, who will then take that further to, let's just say, the parliamentary committees, and we'll kind of touch base on that as we talk a bit further along. So how do we prioritise our work? We have our reactive work, so our day-to-day, we have the free phone number, the email, face-to-face, the events, and the website. So this is a way for members of the public or yourselves or anybody else, whether it's staff, to be able to get hold of us and give us some updates or experiences or how they're finding the health and social care sector. And then we also have our proactive work. So these are 3 deep dive areas, 3 focuses that we've got. So it's access to primary care, face-to-face, being a seldom heard, so somebody from those hard to reach communities, such as the LGBTQI plus community. We also, and our third project is the root causes of good and poor teenage mental well-being and health outcomes when you've been in care as a child. Also, I'd like to add, part of our proactive work, we have the Healthwatch Intelligence Network, which is effectively made up of the VCSE sector members. So at the moment, we sit within Support Staffordshire, who has a contract since 2022, April the 1st. And they have lots of members, probably about 10,000 members that are part of that network, and we're able to tap into that network. And a certain amount of members have now signed up with us as well. So it gives us the ability to be able to reach out to them, get those insights, and then feed that information back from various sources to the right people, whether it's the Health Wellbeing Board, our commissioners, or future contracts within health and social care, and have some influence on making the outcome better for patients. So as part of our reactive work, these are things we are picking up, and some that's been mentioned is lack of access to primary care and secondary care. So that GP access, the 1-1, and then we've got a 111 and the pharmacies. What we tend to notice as trends when people are calling us in when it comes to primary care is it's the access into the places, whether it's the hospitals, the GPs, again, referrals. They seem to be the problem is, and with hospital discharges. However, treatment generally in hospital seems to be positive. We tend to get 90% mostly say, yeah, it was okay, the experience whilst they were in there. It just seems to be getting in there is the problem. Have we had any impact as a Health Watch? Some of the ways that the engagement officers have been helping is to help when people call us in and say they're struggling, let's just say with a GP appointment to get any access, the engagement officers will look at if there's pharmacies attached to the GP practices. That might be another way in. And I know, having spoken to Dave before, there have been carers groups who have really struggled to get the children medicines through their GP, and the engagement officers being skilled enough to be able to make contact with the pharmacies, bridging those gaps, helping those people make the contacts. They're able to get their medicines a lot faster, not having to feel like they're battling against the receptionist at the GP surgeries. And the feedback from that was very positive, and they said that they were finding this to help them anxiety and around making those calls in the morning at 8 o'clock, rushing in the mornings. Now, what we're trying to do as a Health Watch, as much as we are independent from health and social care, is to support them to have that better impact, to add that value and avoid duplication. So we're kind of seeing this at the moment as quite a backed up motorway. And what we're trying to do is just to find extra routes off to help some of those people come off on faster routes for them. And again, something that was mentioned was the lack of NHS dentistry appointments. We received over 70 pieces of patient experience over the past 8 months, which we fed back to Health Watch England. This was collated with other local Health Watches. They received a total of around 700 negative pieces of feedback, which was then taken up to Parliamentary Committee on Dentistry, and that was part of the inquiry, and often the Health Watch feedback was referred to. So we're hoping to get that published back out so we can disseminate what the outcomes are of that inquiry. Again, some of the other issues are issues around cost of living and winter. That hasn't gone away. People are still struggling, especially around rurality and cost of transport. Long A&E waiting times and ambulance times. And again, this is leading to other conditions, especially, and we are talking to our partners within the ICS who are trying to give better advice over the phone when they are calling 999 for an ambulance, especially if they know it's going to take a lot longer. So leaving somebody on the floor for a few hours can then create other complications for any patient. NHS strikes have further impact the waiting times for operations. Delays in hospital discharges. So at the moment, we are recognising as people are getting frailer, they're more likely to enter into hospital. We're trying to look at how we can work better with social care to help be more reactive, to be more preventative. I know the fire service is trying to support this as well. So just to help with that, what tends to happen is, again, somebody's in hospital for 2 weeks, they're not moving as much, and then they tend to have more care needs, and then that delays their hospital discharge, which further impacts that blockage on moving things along. We have been working with care homes as well. What we are picking up is that care homes don't tend to take residents back after 4 p.m. on a normal day, or on the weekends, which again impacts how hospitals can and can't discharge in a more timely way. What I will mention also is our joint enter and view quality visits. So again, our enter and view is our statutory power. We don't have to necessarily have evidence to do a spot check or a visit somewhere. It is our power to go in and be that critical friend. We're not there to necessarily, beat somebody with a stick on negativity. It's more about looking out for that soft intelligence and maybe making those key recommendations to help improve services so that impact for patients is better. We presented this on many occasions with the quality teams across various trusts at the ICS, and this had a positive outcome where they said they have their own internal quality visits that each hospital does at various business centres, and if we could do joint ones. So we are still independent, we maintain that independence, we do it jointly. The advantages of this we found have been that we have minimum disruption because they are already pre-set visits internally with the quality teams. What we do tend to find, naturally, of course, we can go into these places, but it does mean that they have to make reasonable adjustments to allow us to have access, and they're already very stretched. So it's good to see that we can, let's say, piggyback on the back end of the ongoing quality visits, and gives us a chance to have deeper insights into a lot of those places. What we are finding is the maximum amount of output we're getting with the minimum amount of disruption. So we find it's really, really effective. Again, these are reports that we will initially give back to the trust to give them an opportunity to make remedies. In an ideal world, to if you pick up something, they say, okay, these are the things we can put in place, or actually we've now recognised that's a problem, and this is what we intend to do about it before we actually publish those reports. And then you can find any of these reports on our website. If you do struggle to find them on the website, please just give us a shout again, and we can send you the links out directly just to make it a little bit easier for yourselves. Now, what I will do is we're just going to pick up the 3 deep dive areas, quick summary on those, and I'll let Dave now take over on that one.
Right, we started off talking about access to GP practices. This deep dive is particularly looking at some of the issues around primary care right across the county. And there is, believe it or not, there is a massive amount of work going on behind the scenes, although sometimes at the front line it doesn't feel like that. Across Staffordshire and Stoke as a whole, there's 143 GP practices, and between them they're delivering 27,500 appointments a day. So I'm told by the integrated care board, more than pre-COVID. That actually works out at 5.7 million a year, something like that. But there's an increasing dissatisfaction both from patients who are using primary care and the staff that actually work in primary care. And last time I came to this committee a few months ago, we talked about that at some length. So GPs are leaving in droves. New doctors don't want to be GPs, or if they do, they don't want to be partners, they want to be salaried. Some of them think they can have a far better quality of life and far more money if they go to Canada or Australia or somewhere else, where you get far less hassle and better quality of life and better pay. The dissatisfaction, really, the patient focal point for frustration is obviously around the 8 o'clock rush in the morning for appointments. And last year, NHS England commissioned from a GP in Surrey, who's now also the chief executive of their local integrated care board. It commissioned her to produce a report on the next steps forward for primary care. And the report's done by a lady called Dr. Claire Fuller. That's the report. And that has really become the blueprint that all health systems around the country are looking at. Well, there's 3 key themes to that, really, basic themes to that, really. It talks about needing to get away from the 8 o'clock
up in the morning, about trying to segment primary care into the urgent same day work that needs to be done. And so people get seen quickly if they need to be seen on the day and get sent to the right service, etc. There's a whole branch of people with complex needs that really need consistent ongoing support from the practice and the local health care teams of social care and district nurses, whatever. And then there's a whole area of prevention. So try to break that down. And in Staffordshire, the primary care, there's a primary care action plan, strategy stroke action plan that's been developed on the back of this, which was passed by the Integrated Care Board in late April, which sets out the way forward for working with GP practices, who many of whom are small businesses in reality, to tackle some of these issues, which are complex. And the first point on the list, of course, which the government are pushing strongly now, is the 8 o'clock phone call.
Sorry, can I just interrupt for one moment? Councillor Sutton has to leave the meeting for another meeting. Okay, good to see you. Okay.
No.
So there's about 285 million from the government gone into starting to fund GP practices to get more up-to-date and fund systems that can cope with the demands a bit better. Up to a point, it's working. I went to a practice the other day, big practice in Burton. It's got 17,500 patients. They've had a new telephone system. So when you ring up now, you get told, you're so-and-so in the queue. If you want, press this button and they'll ring you back when it's your turn in the queue. So they said, so we waited 2.5 hours to be phoned back when we got to our turn in the queue. So we didn't have to sit on the phone for all that time. We'll make 200 phone calls at the surgery. But then the receptionist said, sorry, but we haven't got anything to offer you now. How you finally got through? But look, all the primary care teams have been told by them, I think it's the middle of this month, to any time soon anyway, but they've all got to be able to come up with a response to people when they ring up the surgery, other than we'll ring you back tomorrow or we haven't got any appointments. So they're going to have to offer people something. So primary care teams are very busy working on that issue at the moment. I mean, there are a number of new types of roles being developed which are emerging in primary care teams, but every practice is different. They've got different buildings, they've got different populations, they've got different numbers of GPs, they've got different needs. But things like social prescribers that can take some of the non-health issues off the GPs, where they can spend more time with patients. There's physio, there's pharmacists working increasingly in primary care now, who can deal with a lot of the medication issues and do medication reviews, organise blood tests, sorts of things really. In some practices, paramedics are now working for GP practices, and they're going out doing some of the home visits. You've got district nurses, you've got surgery nurses, and you've got people called care coordinators that are doing a lot of the chasing around behind the scenes, setting up appointments, and some of the regular screening stuff like blood tests and blood pressure tests and diabetes screening that people require, and so linking up with the nursing homes, because most GP practices now are linked to nursing homes. There's an awful lot going on. We within Healthwatch, we've been talking to patients in all over the county really, and finding out where the good things are happening, and what we can do, working with, and we talk to the primary care people as well. Well, what we can do to put together some sort of guide for patients on how to get the best out of the health service, the primary care service that exists at the moment within the constraints that exist, because there is a shortage of staff. I mean, just on pharmacy alone, in Derby, for example, a lot of the pharmacists that worked in the hospital have gone to work in primary care. Now they've got a shortage of pharmacists in the hospital, so people are queuing all the way down the corridor waiting for their outpatients prescriptions, because more outpatients are being done to catch up on the COVID backlog. Now you haven't got the pharmacists there to prescribe them. So people are fishing in the same pool for the staff. So I mean, staffing resources are a big issue. Perhaps can I just touch on dentistry while
Yes.
we're talking? I've done quite a bit of work on dentistry as well. We attend the Shropshire and Staffordshire network, dental network, where we've got to meet the commissioners of the service. We've also talked to, so we're learning about how it's been commissioned, and the responsibility is just transferred from NHS England to the local integrated care board, and they're the same guys doing the work, just being employed by different persons. Yeah, a lot because of the way the NHS dental contract works at the moment, a lot of dentists have opted out of NHS dentistry and gone down the private route, insurance route, or whatever. It's causing massive problems. We've talked to the NHS, the emergency dental people in Staffordshire, and we've agreed with them a response and advice that we give to patients, because there are emergency dental services available in Staffordshire. There's also dental advice on NHS 111. So we've looked into that, and we've got messages that we can give out to people. We've also, as alluded to, we've taken our feedback, which must be getting on for 100 people at least now over the last year. We've sent that into the parliamentary inquiry in London, and along with other health watches, and I think Lincolnshire on its own had 700 people that they were dealing with on their chief officer from their health watch, and somebody from Health Watch England went and gave evidence at the parliamentary committee at the end of April, and then that evidence was actually taken by that committee, and one of the ministers of health was asked about it. So we are getting the feedback into where it needs to be. I'm told by the guy that commissions services locally that they are intending to shift resource over the next couple of years more and more into practices that are willing to take on NHS work, and some of the regulations are changing. In Lichfield, for example, a practice gave up its NHS allocation, and they managed to get that reallocated to a practice elsewhere in the town, and that practice is now taking on NHS patients and advertising taking on NHS patients. And I've sent people there from Rugeley and Tamworth, and somebody in a wheelchair who needed wheelchair access. So it's starting to shift, but there are all sorts of complicating factors. And again, a lot of the dentists coming out of university want to go and do private practice or cosmetic dentistry, or go and work in Canada or Australia, because the NHS is not the place to work anymore like it used to be. So they tell them. But you know, we are feeding that through, and we are trying to help people to get service. There are parts of the county where there are just no dentists taking on NHS patients at all. And we had one lady a few months ago who contacted us. She's got a 3-year-old child, and she wanted to start the child with a regular visit to the dentist and get them in good habits. She was told we'd be lucky to get an appointment in 3 years. She said, we're thinking of having another child. I think we better register them with a dentist the minute they're conceived, because it's going to be a long time before they get any service. So dentistry is really good. And if you've got particular issues, like the councillor colleague has got feedback from patients, then we're very happy to talk to you about that outside of the meeting and add it to our investigations, and we'll see what we can do to help. But basically, there are not enough GPs. There's too much work when it comes down to it. Often the surgeries aren't equipped for some of them for taking an expanded number of staff. I mean, Burton, for example, their Raleigh Stadium is now becoming the vaccination centre for the whole of the town. It's practices for all flu vaccinations, COVID, or it's been done up to clinical standards to let that continue permanently. It's all sorts of solutions coming up in different parts of the county centre. So you need something that's bespoke to your local population, really.
I just wanted to add as well, before we move on to the next deep dive summary, is just to say that these 3 deep dive areas, we will hopefully have the findings concluded in early November, and we can share that again yourselves if you want some more insights into that. For the second deep dive being seldom heard. So it's reaching out to those communities that are, like we said, hard to reach. We did do some work with some of the communities around the LGBT community, and we did produce a gender affirmation survey and report. Then our report was pretty popular on this. I went to Health Watch England, lots of other local health watchers that were very interested in this area, and across lots of local partners across Staffordshire. This will also be a part of this second deep dive. And again, you can find that on our website, so that's already published on there. What we did find is that every time we done a deep dive into a particular area, even within the LGBT community, we ended up focusing a little bit deeper, ended up with the T, the trans community, and that became its own piece of work. So sometimes it can be a lot more work involved as we get further and further into it to really unpick things. The other three areas, again, will be the Romani traveller community, those people who are living in rural areas, farmers, or those people that can't get internet access in those places or lack of public transport, and those people with neurodiverse, some people like with autism and stuff like that. Now for our third deep dive, I'm going to let Daniela do the highlight on that one.
My deep dive project is titled Root Causes of Good and Poor Teenage Mental Wellbeing and Health Outcomes when you've been in care as a child. This deep dive project is of utmost importance, and it stemmed from our reactive work, having discussions and receiving messages also from care experienced young people and their carers, highlighting the main factors affecting their mental health and emotional well-being, obviously with wider implications across other areas of their life, especially education, training, employment, and also securing adequate housing. We have had meaningful conversation with care experienced young people where they shared with us that their transition into adulthood and independent living has often proved rather challenging, despite having received a range of support and support services, including from health professionals. The main aim of our project is to identify where health, especially mental health services, need to be improved. And in addition to that, also, if there are any gaps in services, to identify such gaps and to address them accordingly. This is to be achieved by working in partnership with the NHS and the integrated care system and integrated care boards, who are undergoing a transformation by reshaping the delivery of service provision. Moreover, we are working alongside the local authorities to achieve this common aim. The overarching, thus the main aim of our deep dive project is to improve health outcomes for our care experienced young people population of Staffordshire in the long term. This, in turn, should have an overall positive impact into their lives, permeating into the areas of stringent need we aimed to address. We will continue gathering the necessary intelligence through focus groups and workshops, as well as one-to-one interventions. We will also promote and distribute some surveys and questionnaires during June to August of this year. And we will have some semi-structured interviews with some professionals. We will be drafting our report, as Baz said, including key findings and recommendations in November time, but the draft report we are hoping that we will have ready around September. And we will be giving updates at regular intervals through similar meetings such as today's South Staffordshire Wellbeing Select Committee and other relevant forums. On the slide screen that you can see in front of you, there are also some bullet points. So
The main themes within the deep dives, according to our findings so far, have highlighted an increased demand with some young people experiencing even crisis point due to a multitude of factors. So they do try to access mental health services, but sometimes they have been slipping through the net. So, for example, if they are a caregiver, there hasn't been a smooth transition into adult mental health services for them. Obviously, that meant that their mental health at times maybe has deteriorated. Obviously, as my colleagues mentioned, there have been pressures within the NHS, a reduced NHS workforce. We know there are recruitment and retention issues when it comes to CPNs and other mental health practitioners. There are referral backlogs and difficulties, as I said, especially with transitioning from children and young people mental health into the adult mental health services. Generally, they want to see a professional to support with their mental health and emotional well-being. Sometimes they are unsure where to go. The telephone access has been impacted by referral queries, and the young people reported to us long waiting times to be seen. The digital access via the website, we are exploring if accessibility via digital platforms has been a smooth experience for young people or if it proved problematic. Obviously, there has been a continued impact of the COVID-19 pandemic with some of the sessions, and I'm thinking about when young people told us that they had the benefit of cognitive behavioral therapies, CBT, talking therapies. Some of the sessions have been face-to-face. However, other sessions have been conducted via Zoom and Microsoft Teams meetings. We are also looking at widening the support networks around the young person and building their resilience. Obviously, liaising with family, with friends, professionals and other support groups in the local community. And we are aiming to improve the health outcomes for care experienced young people by bringing about systemic change within the relevant organizations. Thank you.
So just to on the last slide, just to say looking forward onto the next year. That's the updated slide. So yeah, so just to continue with the deep dives, we are going to continue with the end reviews, the joint one with the quality visits teams. Some of the key themes moving forward that we expect to be engaging in is going to be the hospital discharges, looking at frailty, social care and unmet need, especially with Health Work England doing that as a campaign as well. And it's something that we've been talking to Staffordshire County Council about. Access to primary care dentistry, self-development rurality, and then there's issues around mental health, especially around with George Bright closure and the St George's Hospital that recently has been downgraded from good, the mental health side, down to inadequate. We have had a meeting with MPFT about this and how Health Watch can get involved and help improve that. And that's it. Thank you. So we'll take any questions.
Thank you, Baz and the team. I'm now going to take questions, please. Councillor Hopkins first, and then Councillor Evans. Thank you.
Just a quick question. There wasn't a huge amount of focus on prevention in there. Is there going to be a focus on prevention? That's the most efficient way of saving money and lives. Thank you.
Yeah. You'll start.
Thank you, Councillor Hopkins. I'll pick that one up on behalf of the council. With the change in the scrutiny positions and what can be looked at a county level and what can be looked at district level, predominantly the functions that were scrutinised from a district council function were around prevention. The majority of our services which we provide are prevention based, whether that be leisure, street scene, open spaces, Bagridge Country Park, community safety. Our key focus is prevention at an upper tier level. Your standard or traditional public health services are delivered by the county council. So again, they will be looked at on that footing. Your lifestyle services, stop smoking, healthy eating, physical activity, they're delivered traditionally by the county council. We do run a number of those services locally, which we operate as a district council, and Rob Sharrett at the back of the room over there came to the previous meeting to update on our walking programme and gentle exercise. So we do offer and deliver a number of those programmes. So again, if there's any traditional scrutiny of health, public health, that will be via Councillor Chapman, and we'll pick that up at a county level. That will then be decided whether we can look at it or not. But anything we deliver, Councillor Hopkins, is essentially prevention. So we will obviously be happy to come forward with any presentations or be scrutinised on any of the services we offer locally.
Councillor Evans, please.
Just across the board, a lot's been said, but a lot's been said already. A lot was said in your presentation about the struggle to recruit and retain health professionals. Is there any work that's going on to try and put the new pause to try and address those issues?
Yeah, I mean, we are picking, like I said, we mentioned this because we are picking this up. We attend various ICB meetings, coordinated with various quality teams. We're getting a real small team, but we do try to make sure we're there in many of these meetings as possible. They are trying within the NHS and the ICS to recruit, but there are those. It is a lot to do with cost of living as well. At the moment, there are cheaper offers abroad. That is making part of the impact. The other one is that seems to be the perception right now the NHS isn't a very favourable place to work, so a lot of people aren't looking to that as future work. So they have said they are trying to reach out to the universities and the colleges and the schools to do some that pre-work to encourage people to come into the NHS and work within, whether it's nursing or the GP side. So there is some work going on around that, but I do think it's something that's going to take a little bit of time before it starts to show. And so there's going to be a struggle for the next few years, I'd say.
Well, there should have been a national workforce strategy launched last week, but it's been delayed for some reason. But there's a lot of work going on at the ICB with universities setting up. I mean, one example of where they're trying something new at the moment is practice nurses, the ones that work in the surgeries. A lot of them are going to be retiring in the next few years. So where are the next lot of surgery nurses going to come from? So they've actually set up a course now at one of the universities specifically for training nurses to work in primary care. You're finding, I mean, did a visit to a district nursing team in Lichfield a couple of months ago now. They're running on a 16% vacancy level all the time, and they're saying that every time, they've got very good committed staff, very experienced staff, and they're concentrating on training their staff up to the maximum level that they can get them to, and so they can do things like prescribe medication and cover all these sorts of things. So as soon as that happens, they get a better offer from a job somewhere else in the health service, so somebody pinches them. So, for example, one of the nurses, I think it was in Lichfield, who got a social prescribing, was offered a job in a GP surgery in Tamworth. So she moved, better money, better working hours, no shifts, better, more satisfying job really for her to using her skills. And because 1 in 10 jobs in the health service are empty at the moment. The GP surgery I work in, one of the GPs left 18 months ago. You go on the phone system, and the message at the beginning, his voice is still on the system. He left 18 months ago, and they haven't got anybody to replace it yet. So, it is difficult, but people are trying all sorts of things. It's just, we're talking to the dentists about this. Why can't they do some sort of golden hello system? You come and work in Staffordshire, and we'll We'll give you a golden hello, but you've got a guarantee to stay for a minimum of 2 years or whatever. Bringing back the nursing bursaries, when they've got apprenticeships now for nurses in some of the hospitals. I know somebody who's just started as an apprentice physio in a hospital, for example. I mean, if you go to university, you've got to have 3As to get into food physio. A minute, you go to Kiel, that's what they're looking for. But if you go in as an apprentice and you've got some work experience and you build it up from the inside, then you're a more rounded candidate, if you like, to go on to the next stages of the training. I mean, many years ago, that's how I got into social services. The council that I worked for at the time, which was 200 miles up the motorway, paid for me to go to uni and paid my salary and gave me a job for 2. I had to come back for a minimum of 2 years afterwards, but it sort of retained me for 5 before I left. So there's all sorts of things being tried, and also I think as opportunities emerge, some jobs are more attractive than others. I mean, you see there's some issues around the staffing in the acute psychiatric hospitals at the moment, and Shropshire's actually worse than it is in and one ward in Shropshire's got 64% of its staff are agency at the minute because they can't get people. Shropshire's way out on the limbs from the West Midlands, whatever. We can pinch people from Birmingham or whatever. It comes down to agency social services, for example. Staffordshire pay less for agency staff than Derbyshire and some of the West Midlands people. So where do the agency staff go? The ones that are going to pay them the most money. There's all sorts of things you've got to take into account, and we do. I think they do pinch people from the Black Country and Birmingham into Staffordshire, and probably we get Staffordshire people going the other way as well.
Right.
Thank you.
Thank you very much. I'm going to call upon Councillor Kath Williams.
Thank you, Madam Chairman. Thank you, ladies and gentlemen, for your presentation. It was very enlightening.
Yes.
Do you think you could pass your details on how do we get in touch with Healthwatch to
No.
Sorry, but if you could pass it on, it would be very grateful, and then we've got it at hand. Thank you.
What I'll do tomorrow, Councillor Williams, I'll send out all the presentations from today to members. That the minutes will come a little bit later, but I'll get all those presentations out, and I'm sure we've got that and the team's details, so members can get in contact with Healthwatch directly.
Okay, thank you. Thank you very much for the presentations. As Councillor Williams just said, they were very interesting, and we look forward to having the slides and go through them again. But thank you for that. It's a lot of work there. I'm now going to move on to the work plan 2023-24, update from the Assistant Director of Community Services, Mark Jenkinson.
Thank you, Madam Chairman. In essence, we're at the start of our work programme. We've got one item for our next agenda in September. So following on from Maggie and Mark's presentation today, Chief Inspector Chris Cotton or his deputy Louise Booker will be attending the meeting to give an overall update on the community safety plan, how those actions which Maggie and Mark have spoken about have been progressed, and where we are in terms of some of those outcomes which have been set. So hopefully Chris will be able to do that. In terms of that partnership, we are just one of those partners that form the Community Safety Partnership. So again, just picking up, I know Councillor Sutton's now gone, but we're obviously accountable for the district council elements of that. But again, we can't be accountable for those other partners. So our role is very much trying to work with those partners, influence them, ensure they do the right thing. So again, via Councillor Chapman, I will follow up on a number of those points, particularly ones which were made regarding the housing association. So we will make sure that that representation is fed through on behalf of the committee.
Thank you, Mark. Any questions, please? No. All right. Thank you very much.
And sorry, Councillor Chapman, again, just to reiterate, members, it is a members-led committee. So if you have got any specific areas that you want to bring forward, please either let myself know or via Councillor Chapman, and we'll ensure we get the relevant teams to attend the meeting. And hopefully it's more productive if it's areas of work you want to look at from a committee perspective.
Thank you, Mark. So we'll now move on to any other business. Anyone, have you got anything to raise, please? Councillor Bernard Williams.
As you said, we could talk about the places that we represent. And air quality is something that is constantly brought up at Chesley Bay. So in all good whodunits, it's always somebody who you would never expect who's done it. And the question is that down at Four Ashes, we have an incinerator. And people are complaining that they do believe that from that incinerator, they do get ash on the tops of their cars in Chesley. On a personal note, I will tell you, late at night, you do see smoke coming from that chimney that you don't see during the day. In other words, much more smoke at night. Now, maybe what they're doing is burning things they wouldn't burn during the day. I don't know. But when you also have a smell with it, a sweet smell, if you want to, like leather, that's something else that we've experienced that shares still. And also, we have seen like spots that disappeared during the day that follows at night here on the roads, and maybe, I don't know, everywhere else. So I don't know whether that is actually happening due to the incinerator or what. But I do think where air quality is concerned, if we could check that that incinerator is doing the job it's supposed to do 24 hours a day, not just during the light hours, then I think we should do that. Now, I'm not blaming the incinerator for anything. I'm just telling you what happens, what people are considering is happening, and they would like something done about it, because the amount of smoke that comes out at night sometimes is quite horrendous, like an ordinary chimney. So that's something we need to have checked.
Thank you, Councillor Williams. Mark Jenkinson, please.
Thank you, Madam Chairman. Yes, Councillor Williams, it's something we can put on the agenda item for the next meeting, and I'll liaise with colleagues in our environmental health and licensing team, and they'll be able to come and talk to the committee regarding that, and again be able to indicate whether they believe there is any issues in relation to the incinerator, or whether it's caused by potentially other smoke outlets in that location. But again, we'll invite the team to come and speak about that at the next meeting. Councillor Williams.
Questions, please. Okay, thank you very much. Well, the meeting is drawing to a close. I know on your behalf, I'd like to thank all of the presenters. They've been very, very informative, and we do, as I said earlier on, we look forward to the slides, but we've covered a whole wealth of subjects. And also, councillors, I'd like to thank you for your attendance today. And we go into the new term of office of councillors. So thank you very much for coming.
Thank you, Chairman.